Yes, we can.
Okay, perfect. And yeah, okay. Thank you, Dr. Lottie. Thank you, Dr. Lyons, for giving me this opportunity. Thank you also to our libraries for this partnership, to the CNC, and thank you all for joining. We're glad that you have an interest in this topic. We're glad you're here. Let's see. So, okay, I have some people waiting. Okay. All right. I'm gonna try and keep this on the side. I know people are still joining. Okay. All right. So, as Dr. Lottie mentioned, we're going to talk about COVID and its effects on the brain. And we're going to try to divide it into two main things. We're going to talk about its effect on the nervous system, so neurologic complications, and also talk about its implications on mental health. By now, most of you know, COVID-19 is a disease that is caused by coronavirus. The virus is called SARS-CoV-2. It is a very highly contagious virus. It is a type of a coronavirus. Coronaviruses are very common. They are very common in the community. Very common during sort of the winter season, a lot of flu-like illnesses caused by coronaviruses as well. But these are unique. We had previously a small epidemic caused by SARS-CoV-1 and an even smaller epidemic caused by a different coronavirus called MERS-CoV in 2003 and 2012. But those were very, compared to what we have now, those were much smaller epidemics. And when you look at the structure here, you can see this is kind of the structure of the virus. It has these spike proteins, and because that is kind of what looks like, the corona shape, which is how they get this name. It is now very well known that the COVID-19 disease occurs because of what we call airborne transmission. The virus is spread from person to person. It's a highly contagious virus, and it occurs because from the mouth, the nose, the breathing system, it is transmitted from one person to the other. How does it enter the body? Once the virus comes in close contact, once the virus comes in close contact with the surface, it is transmitted through the nose, through the mouth. Those are kind of the common areas where you have this receptor that's called the ACE2 receptor. So think of it as a lock and a key. We have our own immune system, our defenses, that normally prevent the virus from coming in. The virus has to attach to something to try to make it into our body. And what the SARS-CoV-2 virus utilizes is something called ACE2. So this is a receptor that is present very commonly in the nose, the mouth, and that's how it enters our system. Once it enters our body, it triggers our immune system. Our immune system is designed to fight organisms, to fight viruses. And when it comes in contact with our immune system, it activates the immune system. And when the immune system is activated, its job is to try and fight the virus. But as it tries to do that, it also causes significant inflammation. And it is that inflammation that leads to damage. The inflammation occurs primarily in the lungs, but we will talk about how the same thing can also occur in other organs. Also, what happens as part of this inflammation is it triggers a different cascade, and that different cascade is that of our coagulation system. So we also have a system where our blood can clot, and it maintains a balance where it doesn't clot all the time. It lets it stay fluid, but when needed, it can clot. That system gets imbalanced as part of this secondary response from the inflammation. which is why we also see quite some clotting and other problems, either clotting or bleeding, that we see in patients who have severe COVID-19 disease. So this is kind of, what is well known with COVID-19 is that it can affect the lungs. It enters, like I said, enters through the mouth, through the nose, and it makes its way primarily into the lungs. Those ACE2 receptors are present in abundance in the lungs, and that is its primary target. And it can cause a lot of difficulty with breathing and changes in the lungs where it really impairs breathing. As time has gone by with this pandemic, we have realized, in fact, I would say that some of these things were realized really early on, that it is very different compared to other, respiratory viruses, because it can affect other parts of the body besides what we think of as our breathing system. And it affects all these different parts of the body, heart, our digestive system, kidneys, the neurologic system, and which is what we are going to focus on, our neurologic system and the mental health aspects as well. As I was saying earlier, it can affect our blood system too and cause problems with clotting and coagulation. So today we'll talk primarily about the brain. These are some of the very, very common symptoms that patients with COVID experience early on, very early on. So the most common symptom being headache. Headache is a very, very common symptom in COVID. As patients have fever, some difficulty breathing, cough, those are common early symptoms. But along with that, what is really noted is headache, loss of smell, loss of taste are very common symptoms. There are other neurologic complaints as well, like muscle aches, muscle pain, dizziness, nerve pain. Those are very, very common symptoms. To give you an idea, at some point, about 94% of patients have had some neurologic symptom, when they develop COVID. This is a little bit unusual. This is unusual compared to other viruses. Headaches may be common in influenza, but the unique thing about COVID is this loss of smell and loss of taste. Oftentimes, some patients who have some runny nose may get this loss of smell and loss of taste, but we see it in much, much higher proportions in patients who have COVID-19 compared to others. And that makes us wonder if that is kind of, a way how the virus may potentially enter the brain. So while we think of these symptoms as being more part of the early kind of presentation, what we actually notice is some worse complications or some more severe problems when patients have severe COVID-19. So severe COVID-19 disease involves, I'm sorry, I'm not able to, okay. I'm sorry. The severe COVID-19 disease is when patients are really sick and have lung involvement. They usually have such great difficulties breathing that they have to be on a ventilator. When patients have those kind of severe complications of COVID-19, they can develop other neurologic complications. One of them is strokes. Stroke can be of two types. Patients can either get a hemorrhage, or patients can also get a clot in the brain, in the blood vessel in the brain, which can cause some damage to parts of the brain. Here are shown some images. This is, these white dots that you see, they're small strokes. So in this case, you can see that this patient had developed strokes on both sides of the brain, many strokes, many small strokes, in a patient who had severe disease in the lungs. The other complication here, you can see a very large stroke in a patient. Here, what you see on this scan are some hemorrhages in a patient. The other complications that some such patients who have really severe COVID-19 develop are seizures. So we have seen patients who have never had seizures ever before, but they develop seizures as part of this COVID-19. The bigger thing that we see is something called delirium or encephalopathy. What that means is patients get very, very confused, or oftentimes they are in this comatose state from which it is very hard for patients to wake up. And again, these are patients who are, who in general have very severe disease. When patients are intubated, that is part of often the process that we put patients on some medications to keep them comfortable so that the tube in the throat is not, does not bother them, keeps them comfortable. What we see in patients with COVID is that even when those medications are lowered down, they have great difficulty waking up, meaning that they kind of persist in this comatose state for a long time. And this is very, very different than what is seen with other, other infections of the lung, including influenza. That part is very, very different. The other thing that we see is this memory loss or fog, like patients have often described what they call a COVID fog or a brain fog after COVID. And that is, again, we're still learning a little bit about this disease, but this is something that what we call survivors also describe, meaning patients continue to have them even after, let's say, they have recovered or, they have been able to get off the ventilator. They are awake, but that they kind of continue to have these sort of cognitive difficulties. So who is at risk for developing these such severe and kind of scary neurologic complications? So patients who have obesity, who have diabetes, who have high blood pressure, who have some kind of heart problems, often those who have had coronary artery disease, which means, heart attacks previously, and patients who have a history of smoking. We know that these are risk factors for developing what we call severe COVID-19, meaning these are the same patients who will probably have severe disease from COVID-19 as well. And these are the same patients who also tend to develop neurologic complications related to that. And so the treatment for severe neurologic complications, again, thinking back to this diagram, we tend to try to manage things thinking along the same pathways to what caused it. We try to manage that. So one of the first things that we try to do is use medications against the virus, which is, remdesivir, as that's available. We try to manage the oxygen levels in patients, and the oxygen levels include, like putting them on ventilator if needed, or other methods by how we can maintain the oxygen levels in the brain. Because if you can manage their oxygen levels in the blood, that is how you can manage their oxygen levels, kind of, keep their oxygen levels up in the brain. We give these patients steroids to try to reduce this inflammation, the cytokine storm. We sometimes use some other medications to try to reduce this inflammation as well. You may have heard of something called tocilizumab or other drugs. Again, depending on the severity of where the patients are, that's how we tend to use these medications. As I mentioned earlier, some patients do have clots that cause strokes, which is when, if needed, we may need to use some blood thinners. And sometimes we may, if these patients have developed seizures, we may need to use some seizure medications. This is something that you may have heard of a lot, and something that we certainly see much more commonly as months have passed, which is what patients, will call kind of long haulers or long COVID. This means that these are patients who have recovered from COVID-19, but still continue to report ongoing effects of infection. I mentioned memory loss earlier. We don't, at this point, we don't think that that is equivalent to, let's say, developing a dementia, but we do know that these patients have this complaint of memory loss or fog in the brain. Patients may have recovered from their symptoms of breathing, or fever has subsided, their breathing may have improved, but they continue to have these symptoms for a much longer time than what we would expect, from such viral or respiratory illnesses. We try to help manage these patients. We definitely have sort of clinics to try to help manage the symptoms that these patients experience. So that's kind of my part of the talk, and I am going to pass this on to Dr. Powers. Dr. Lati, do you want me to take questions at this time, or maybe let Dr. Powers finish his presentation first, and then kind of both of us can take questions? Sorry,
Dr. Lati, I think you may be muted.
Just noticed that. Yeah. So why don't we take the question at the end? Let's Dr. Power go over his presentation.
Okay, I'm gonna make you the host, Dr. Powers.
Thank you. Hopefully I can manage this. Okay. I'm going to advance, alert everybody in advance that I'm probably the least technologically adroit person on this call today.
I was going to comment that for a bunch of old people, we're doing pretty well with tech.
Speak for yourself.
Okay, and let's see. All right. Well, I'm going to talk about the psychiatric aspects of this. And I just want to begin by saying, if you conceptualize COVID-19 experience as being a disaster, and the reason that I like to think in those terms is that as the medical director for the Department of Mental Health, I dealt with Katrina and the BP oil spill and the tornadoes. So I have some experience in what happens with these kinds of catastrophic events. And one of the things that always happens is that there's a mental health aftermath. So we shouldn't be surprised by that. And these are just some well-posted numbers. That's why FEMA, as part of its response, always has a mental health component to come in and try to help out. When we talk about, in Alabama, we've lost 2,300 citizens from COVID-19. Out of the last I saw on the Public Health Board, 135,000 positive tests. The real question is how many folks have died? And in my opinion, since I'm the pathologist in the group, I think about those kinds of things. It's probably more than we realize. And the reason is that in addition to people who develop medical problems and die as a result of the COVID infection, you have the indirect casualties resulting from the disruption of the healthcare system, both physical health and mental health. And the studies, this is out of MMWR data from June, showed that there was a substantial reduction of emergency room visits in some localities. The overall number of people coming in with STEMIs and getting treatment for STEMIs dropped, although there was no evidence that the rate of heart attack had been reduced substantially in the population. And if you look at all of those statistics, by the way, the fourfold increase in infectious diseases, I suspect is that, if I didn't know much about COVID and I had a bad cough or was running a fever, I might want to go visit my emergency room out of fear. When we come to trying to suppress anxiety, helping people to not feel distressed by any somatic symptom they may have that suggests COVID may be a benefit, and that gets to rapid testing. This, in addition to causing direct casualties, it's disrupted our ability to deliver preventive care. As well as the rates of people coming in for chemotherapy dropped, people getting their colonoscopies dropped. So we really don't understand the long-term aftermath of this, but I suspect that it's going to be substantial. When you talk about the mental health aspects of COVID, it depends on which group you're talking about and in what setting you're looking. It depends on the stage of the pandemic. You know, if you were sitting out in the Badlands of North Dakota, South Dakota 4 months ago, it probably was not particularly stressful because the rates were really low. But now after the Sturgis experience, your rates may actually be somewhat higher. It depends on the age of the individual. Interestingly enough, older people may be less stressed under certain circumstances. Many of the studies show that 18 to 24-year-olds are showing a lot of stress because this is really disrupting their life plan and their life in general. So impacted by medical comorbidities. Obviously, you would have, if you have cardiovascular disease or pulmonary disease, this is going to probably increase your stress level a lot more. Impacted by psychiatric morbidities, we'll talk about that in a little bit. It also depends on the severity of the complications. If you're young and get COVID and run a fever or are asymptomatic, it may not create much distress. On the other hand, if you are older and have cardiovascular disease and you wind up in the hospital or on the vent, it's much more likely to produce psychological issues. And it also depends on the group. And I want to just briefly talk about healthcare professionals because I'm very worried about the overall mental health of our healthcare professionals. A lot of the data that we know on the mental health comes from older data out of the SARS and the MERS, smaller and somewhat biologically different epidemics. But the benefit is that we were able to follow some of these patients out for anywhere up to 12 years to figure out what is the long-term psychological aftermath of having a coronavirus. And here are all the caveats that go along with trying to interpret any sort of data off SARS or MERS. This is from Rogers et al., which is Lancet, which is a meta-analysis of most of the reputable studies done on the psychological aftermath for people who are hospitalized with either COVID, SARS, or MERS, looking at both the acute phase of during hospitalization, you know, what were you experiencing when you were in the hospital, and then looking at longer term, anywhere between 3 months or 12 years. And what you found was that depression and anxiety was up significantly during the acute phase, but was persistent later on. Memory problems were a fairly common and consistent finding. And I get queries a lot about, you know, if you're older when you have memory problems, then people start to wonder whether or not they're developing Alzheimer's disease. I always remind folks that Alzheimer's disease does not come on suddenly, but in a very rare situation. Sleep problems are fairly common and somewhat persistent. The confusion is really mostly delirium, and it's seen in the acute phase. However, irritability and fatigue seem to be a common denominator that run through SARS, MERS, and probably COVID-19. There is a recent publication looking at people a couple of months out from COVID-19 infections, and the fatigue seems to be a persistent symptom that you see in those individuals with regards to the psychiatric complication. So something that looks a lot like chronic fatigue. What do we know about substance abuse in COVID-19? Well, if you look at data that was put out by the federal contractor that is paid to monitor overdose data, they indicated that recently 61% of the reporting counties were showing an increased rate of overdoses. And they calculated there was about a 16% increase in the number of overdoses over the same time period pre-COVID. Likewise, the distillers, even though the bars are closed, the distillers are doing quite well. They're selling more alcohol. We don't have a whole lot of data on substance abuse. Now, there is newer data coming out. This is MMWR data looking at the overall mental health in the general population. And this was from a very large end. It's good data. And what you can see is that about 40% of respondents, when queried as to whether or not they had behavioral, any sort of mental, psychological, behavioral health problems during the COVID-19, were saying, yeah, they had at least one symptom. And as you can see from the numbers comparing, and this is in the general population now, this is not necessarily in people who had COVID or were hospitalized. What you see is the numbers climbing in the middle column from 2019 to the COVID column in 2020. For instance, depressive symptoms from 6.5 to 24%. Suicidal thoughts, and I would remind you that the existing data in Alabama prior to COVID was about 4% of our population on an annual basis has thoughts of self-harm. But you can see that there has been a substantial increase in rates of harming themselves, as well as increased risk of substance abuse. So the evolving data indicates that there is a substantial mental health impact from this. If you focus down, this is from a JAMA article, which is pretty well sourced in the general population. You can see that the people endorsing mild, moderate, and severe depressive symptoms, not diagnosed, but depressive symptoms, has substantially increased over the same time period from the year before. So I think it's fair to say that the general population is experiencing more mental health symptomology, and certainly the persons who have sufficient COVID disease that they wind up requiring acute medical care have had substantial psychiatric symptoms. What about the work? What about our healthcare workers? You know, I think all of the data on both SARS and MERS, as well as the data coming out of China, showed a substantial mental health impact on the healthcare workforce. And it's attributed to many things. Having to care for patients, large numbers of dying patients, or patients who are suffering severely. You know, there have been 7,000 healthcare providers in the state of Alabama who have contracted COVID, 7,000 healthcare workers, I should say, who have tested positive for COVID. So our colleagues are seeing their friends and colleagues come up positive. There's the family stress associated with what's been going on within the workforce. There's been the financial impacts because the hospital budgets, as we all know, have been taking a severe hit. And then there are societal stresses. It's important to remember that about 25% of the healthcare workforce are parents between the ages who have children less than the age of 12. And they're now all struggling with childcare. So this is the healthcare workforce historically has been stressed under these circumstances, and I suspect is already seeing a fair amount of stress. So what were the conclusions that I drew looking at the healthcare workforce? Is that the closer you are to the more severe illness, probably the more likely you are to have symptoms. However, even if you're at the periphery, studies out of China indicate that you will experience increased stress. The more you know about it, the better your PPE that you have. Those are all things that at least out of the Chinese literature, they thought mitigate stress, and that they think that that behavioral health issues during the middle of the COVID pandemic may account for a substantial loss in the workforce. So this is going to be something we're going to have to deal with when the second wave comes, and I'm very fearful that there is going to be a second wave. What about, now we've talked about the biology in the brain. I mean, what's the direct effect in the brain? Well, what about some of the other things that happen in society as a result of the illness? Social distancing, quarantine, unemployment, financial loss, externally imposed constraints on people who simply don't want to be constrained, don't want to wear a mask. What's the aftermath of all of that? And I will tell you that that there's a lot of things going on at play. As a psychiatrist, you know, if you watch scary movies, it's never the monster or the dangerous person who's stalking, who faces you on the screen that scares you the most. It's the person who's in the shadows that you don't see that's the scary character, that's lurking behind there. Every good horror filmmaker knows that. You know, don't go in the basement. And so, you know, fear of an invisible threat is considerable. And there's all these other issues that you would imagine. And there are a lot of angry people. I will tell you that there's a growing body of data on loneliness in society. And there was already problems with loneliness in our society prior to the onset of COVID. And most of the authors seem to believe that the COVID pandemic is making that loneliness worse. So I do want to put in a plug for people that I care a lot about. I am an advocate, and that is persons with serious mental illness, persons with dementia, and persons with developmental disorders such as intellectual disability and autism. I want to remind folks that this has been hard on those individuals because of the social isolation. Many of these individuals may go to a school or a day program or a sheltered workshop for persons with intellectual disability. That is the core of their day, and they have been isolated from those activities which are so dear to them. So it has been hard, especially on individuals with those kinds of neuropsychiatric disorders. So what about people who are forced into quarantine? Well, the studies, there's actually a lot of data on quarantine. There was the SARS and the MERS old data. There was the equine encephalitis data. And all of the indicators indicate that quarantine is hard on your mental health. And these are the typical kinds of symptoms that you would expect to see. So even if you don't get COVID and you're not going broke because you're out of work, just being isolated probably is a significant psychological stressor. What are some of the issues that people in quarantine worry about? Lack of reliable information. Wouldn't we like to really have a constant source of reliable information? And by the way, these are all things that can be done to lessen the burden. Likewise, fear about the outcome. What about suicide and impoverishment? The studies all show that there seems to be a link between increased risk for suicide and percentage of unemployment in the general population. There also seems to be an increased risk of substance usage and unemployment in the general population. And likewise, domestic violence tends to go up with unemployment and increased substance use. And some of the law enforcement officers that I've spoken with have indicated that they believe that they're seeing increased risks for domestic violence. So what can we conclude from all of this? Well, we think that where you are in the stage of your illness, the severity of the symptoms has some impact on your overall psychiatric morbidity. That social stressors, financial stressors are probably going to increase these things. And that there are racial and socioeconomic disparities that are very, very important. We know that the people based on the MMWR study having the highest rate of distress were persons of minority between the ages of 18 and 24 with the lowest socioeconomic strata. Now, what could we do to maybe help things? Well, you have to take the Chinese literature with a grain of salt. The reason is that especially when they talk about public policy, there may be other pressures that the authors are experiencing. But all of that aside, the Chinese did some fairly interesting research looking at cross-sectional changes. And what they found were a couple of interesting things. First of all, the more somatic symptoms that you had in the general population that would lead you to believe that you have COVID, regardless of whether you have COVID or not, seem to increase your psychological distress. And they made the point then that's why you need rapid testing. Because the best antidote for fear that you have COVID is to have a test that says you don't have COVID. Increase public education, especially in hygiene matters. They believe that was a linchpin of their success in suppressing it. They found that radio advertisement did not help, but what they did find that television advertisement using trusted public officials seem to help. They found that increased masking reduced chronic anxiety. That's what they believed. And increased social distancing seemed to give people a sense of empowerment and seemed to lower their anxiety. The reason that I mention this, these are all simple things that we could do right now to try to reduce the overall psychological burden on people if we had a national plan that was comprehensive. I think it's fair to say that the psychological aftermath is unclear, but will probably be fairly considerable. Okay, so I'm trying to stop share now.
Perfect.
Okay, and I am going to surrender gladly Dr. Lottie. Hold on just a second, Dr. Lottie. I think I can do this.
Okay. So, well, thank you very much to both of our speakers today. That was really very, very interesting. So we're going to open it to questions. And I think the best way we can do that is you could raise your hand and I can read your name. And then I will call your name, you unmute yourself and you pose a question. Or there's also a chat, where you can type question. And then I will monitor the chat room. And if I see a question, I will read it to you. So I see someone raising your hand. This is Sue. Okay. Can you unmute yourself, Sue?
Thank you for this presentation, first of all. I have a question about the impact of the virus on the brain in terms of memory loss and possible strokes. It seems like we have a good handle on how to treat the impact on the lungs, but what are we doing once somebody is diagnosed with COVID to help prevent the impact on the brain?
Yeah, thank you for that question. That's a very good question. I'm going to try to answer that. I think that's, the effects on the brain are very much secondary to what happens in the lung and in our immune system in the body. So what we try to do is try to kind of manage those things. One of the big things, one of the reasons for this kind of memory loss is lack of oxygen to the brain, right? And that happens when the lungs are affected. So we try to manage the oxygen levels. We try to, if patients are developing clots, we may put them on blood thinners. It is a little bit tricky because, as I said, sometimes we actually see hemorrhages in the brain as well. So that is a little bit of a tricky decision that clinicians need to make. But those are the types of things that we do. There is also, like I said, some medications that we use to actually help calm the inflammation down. So if we can actually keep the inflammation in check, we hope that prevents the down cascade, which is, it prevents this clotting problems. So those are the type of things that our critical care specialists are very good at, and that's what they do.
Thank you.
I'd just like to add one thing. We've looked at the brains of about 30 individuals who died from COVID-19 at UAB. We've been doing it for a number of autopsies, and that's a select population. There's no evidence that individuals with COVID-19 have accelerated neurodegenerative diseases like Alzheimer's disease or such things. And the changes that we've seen and the changes that are reported in the general literature are the kinds that are associated mostly with metabolic changes, whether it be low oxygen or other organ type problems like liver failure. So that's sort of the good news, because then one could hypothesize that those things ought to reverse themselves over time as opposed to having widespread neuronal loss. The other thing they don't get is they don't get encephalitis like you see in viruses like herpes in any great number. There's a few cases, I think I maybe have one or two, where it's a possibility, but it's no raging encephalitis such as, like I said, you might see in herpes.
The reason I asked that question, and I don't want to take over the conversation, is that my husband was tested positive on Monday, and he's in the hospital, and his first symptoms that I noticed was the confusion and the physical weaknesses in his body. And so, but in the hospital, you know, his lungs and everything seemed to be doing well. So it seems like, you know, it didn't follow the process that you had explained, where you get the inflammation in the lung and then it leads to problems with the brain. So that was the reason for asking that question, is his symptoms seem to be neurological first. So thank you.
And I think one way to answer that or explain that is what we see in older patients often is that, and that happens with a lot of infections, that is not something that is unique to COVID-19, is that older patients are more prone to developing this sort of confusion with any infection that they get. That is what we call delirium. And that is, as Dr. Powers was saying earlier, we think of that as being reversible, in the sense that as that infection is treated, and that happens when patients develop, let's say, urinary tract infections or other pneumonias or other infections. And those patients actually tend to come back to their previous baseline as that infection is treated.
Okay, I have a question in the chat. That's from James Sedlis. While there is data that dexamethasone can decrease the incidence of death with COVID, is it decreasing the occurrence of stroke and other adverse neurological deficit?
That's a very good question, and the answer is we don't know yet. We suspect, or we postulate, that because it helps with the inflammation, that it may help reduce some of those problems, but